The cranial cruciate ligament is a tough band of fibrous tissue that connects the femur to the tibia. Think of the CCL as a positioning rope. Its entire job is to keep the femur and the tibia in their correct positions. Primary function: to prevent tibial thrust. As top of the dog's tibia is sloped backward, every time the dog puts weight on its leg, this slope naturally wants to make the tibia thrust or slide forward out from under the femur. The CCL is the primary structure that stops this from happening, providing stability with every single step. Secondary functions: prevents hyperextension, stops the knee from bending the wrong way, limits internal rotation, to prevent tibia from rotating too far inward. Unleashed joint GPS. It has nerve endings that tell the brain where the leg is in space.
Examination by a veterinarian. A veterinarian will use a combination of history, observation, and hands-on palpation. History. The owner may report sudden severe lameness after playing, a mild intermittent lameness that has suddenly worsened, difficulty rising or jumping, a lazy sit where the dog avoids flexing the painful knee and instead sits with the leg out to the side. Gait analysis. The vet will watch the dog walk and trot to confirm the lameness and observe how the leg is carried. Physical exam, palpation. This is the most crucial part. Joint effusion. The swelling, fluid within the joint. Medial buttress. A firm swelling on the inside, medial, aspect of the knee. Cranial drawer test. This is the gold standard test. Cornerback compression test, tibial thrust.
Diagnostics, radiographs, X-rays. Primary purpose. X-rays cannot visualize the ligament itself. It's soft tissue. However, they are essential for confirming joint effusion, swelling, detecting signs of arthritis, osteophytes, indicates chronic disease, ruling out other causes of lameness, e.g., fractures, bone tumors, surgical planning, measuring the tibial plateau angle for TPLO, TTA. Advanced imaging, less common. Arthroscopy, a minimally invasive surgical procedure using a camera to look directly inside the joint. This is the most definitive way to diagnose a tear, especially a partial one, and assess the menisci, cartilage pads. MRI can visualize soft tissues, but its cost, time, and the need for general anesthesia make it an uncommon diagnostic tool for CCL tears.
Treatment options are divided into non-surgical, medical, and surgical management. Non-surgical medical management. Candidates: very small dogs, older dogs with severe concurrent diseases, making them poor anesthetic risks, or situations with extreme financial constraints. Strict rest. 8 to 12 weeks of crate rest and leashed-only potty walks. Weight loss. This is the single most important non-surgical factor. Medications. NSAIDs, for example, carprofen, meloxicam, to manage pain and inflammation. Physical therapy. Controlled exercises to maintain muscle mass. Joint supplements. Glucosamine, chondroitin, omega-3s. Outcome. The goal is for scar tissue to build up and stabilize the joint. This is a functional stabilization, not a true fix. These dogs will have more severe arthritis and mobility issues.
Surgical management. This is the recommended treatment for almost all pets. Land suture-based ligament replacement techniques. Extracapsular lateral suture, ECLS, or flow technique. How it works. A strong, heavy-gauge nylon suture is placed on the outside of the joint capsule, anchored around a bone in the femur, and looped through a tunnel drilled in the tibia. It mimics the function of the CCL, preventing the tibial thrust. Pros: lower cost, less invasive, shorter surgical time. Cons: the suture can stretch, loosen, or break over time. It relies on the body's own scar tissue to provide long-term stability. Generally best for smaller or less active dogs, less than 40 to 50 pounds.
Tightrope surgery for CCL tears in pets is a minimally invasive orthopedic procedure designed to stabilize the stifle, knee, after a cranial cruciate ligament CCL, rupture. It uses a strong synthetic fiber tape placed through small bone tunnels in the femur and tibia. This tape acts like an internal brace, mimicking the original ligament's job, preventing the tibia from sliding forward and controlling rotation. How it works. Small bone tunnels are drilled at particular anatomical landmarks. The fiber tape is passed through these tunnels in a pattern that replicates the natural CCL's orientation. The surgeon tightens and secures the tape externally, then buries the knots. The tape provides instant stability, protecting the joint while scar tissue forms to support long-term stability.
Osteotomy, bone cutting techniques. These are more advanced procedures that alter the geometry of the legs to neutralize the tibial thrust force, making the CCL obsolete. 1. Tibial plateau leveling osteotomy, TPLO. How it works. This is the most common gold standard procedure. The surgeon makes a curved cut in the top of the tibia, the tibial plateau, and rotates it to a flatter angle, for example, from a 25-degree slope to a 5-degree slope. A custom bone plate and screws are used to hold it in place while it heals. Pros: excellent long-term outcome, rapid return to weight bearing, considered the best option for large, active, or working dogs. Cons: higher cost, more invasive, requires specialized training and equipment.
Tibial tuberosity advancement, TTA, stabilizes the stifle by repositioning the tibial tuberosity, the bony prominence where the patellar tendon attaches. Here's the functional concept. A linear cut is made along the front of the tibia to separate the tibial tuberosity. The tuberosity is advanced forward using a specialized cage, plate, and fork system. Advancing this bone changes the patellar tendon angle to approximately 90 degrees relative to the tibial plateau. At this angle, the cranial tibial thrust is neutralized, meaning the joint is stabilized during weight bearing without relying on the damaged CCL. There's no rotation of the tibial plateau, unlike TPLO. Instead, TTA alters the biomechanics of the extensor mechanism to compensate for the ruptured ligament.
Recovery and aftercare. The postoperative period is critically important to the success of the surgery, especially for osteotomy, TPLO, TTA procedures. Immediate post-op, weeks 0 through 2. E-collar, cone. Mandatory 100% of the time to prevent licking or chewing the incision, which can cause infection and failure. Strict confinement. The dog must be in a crate or a very small confined room. No free roaming. Activity. Leashed-only potty breaks. No running, jumping, stairs, or furniture access. Medications. Pain meds, NSAIDs, gabapentin, etc., and potentially antibiotics. Icing. Icing the knee for 10 to 15 minutes, 2 to 3 times a day, helps reduce swelling. Early recovery, weeks 2 through 8. Suture removal, around 10 to 14 days. Confinement, still very strict. Activity, begin very slow, controlled, 5 to 10-minute leashed walks on flat surfaces. Exercises, passive range of motion, prom exercises, where the owner gently flexes and extends the knee, may be prescribed. Rehab, formal physical therapy, underwater treadmill, laser therapy can be started. Late recovery, weeks 8 through 12. 8-week X-rays. For TPLO, TTA, follow-up X-rays are taken to confirm the bone is healing properly. Gradual increase in activity. Only after X-rays confirm healing, activity can be slowly increased. This includes longer leashed walks, gentle hills, and building back muscle. No off-leash activity. Most surgeons restrict all off-leash running, jumping, or hard play for a full 12 to 16 weeks. Late recovery, weeks 8 through 12 plus. 8 through week X-rays. For TPLO, TTA, follow-up X-rays are taken to confirm the bone is healing properly. Gradual increase in activity. Only after X-rays confirm healing, activity can be slowly increased. This includes longer leashed walks, gentle hills, and building back muscle. No off-leash activity.
Most surgeons restrict all off-leash running, jumping, or hard play for a full 12 to 16 weeks. Long-term management. Full recovery. It can take 4 to 6 months to regain full function and up to a year to rebuild all atrophied muscle. Arthritis. Arthritis is an unavoidable consequence. The joint was unstable and then had surgery. The goal of surgery is to slow down the progression of arthritis and provide a pain-free functional joint.
Two of the most significant consequences of a CCL tear, and it's a crucial points. Joint inflammation leads to arthritis. The moment the CCL tears and the joint becomes unstable, it triggers immediate and significant inflammation, synovitis. This is the body's response to the abnormal motion. This inflammation is what causes the joint effusion, swelling, is a primary source of pain, and leads to the irreversible joint damage we call osteoarthritis, OA. Meniscal injury. This is a very common secondary injury. The menisci are cartilage cushions inside the knee. When the CCL is torn, the tibia slides forward, cranial tibial thrust. With every step, the femur can slide and pinch, crush, or tear the medial meniscus. This is extremely painful, and often the reason a dog's lameness worsens.